If you suffer from burning at the ball of your foot, cramping, stabbing, electrical shocks into your third and fourth toes, or do you feel like there's a rock stuck in your foot, in your shoes, near your third and fourth toes? Well, you may have Morton's neuroma. Let's stop all that. In this video, I would discuss the latest treatments, and as a podiatrist, what's helped my patients, as well as how I myself has dealt with the Morton's neuroma for the past 25 years without expensive procedures and surgeries.
Hey everybody, it's Dr. Gaffney from Dr. Gaffney Best Foot here, sharing tips and tricks of what has helped my patients over the years in order to save you time and money in your foot care decisions.
So what is a Morton's neuroma? And it's normally a pinched nerve. It's a thickened nerve from scar tissue near the third and fourth toes, and usually near the ball of the foot, and it radiates into the toes. It typically starts as a neuritis or a nerve inflammation, and over time with stress and trauma, fibrosis or scar tissue develops, causing the nerve to thicken, and it turns into a neuroma. Also, it gets very swollen as well. So what causes a neuroma? We don't really know fully, but it's thought to be a compression or a traction type trauma causing the nerve to get impinged or entrapped. So in the third web space near your third and fourth toes, there's a space between the metatarsal bones. So the metatarsal bones, the heads of those bones make up the ball of the foot. And the nerve can be thickened anatomically here from two nerve branches coming together. And that makes that area thicker and more susceptible to trauma and irritation. There's mainly biomechanical causes, so how your foot moves. And so the outside part of your foot, there's an area, a structure of bones, and we call that the lateral column. So that area has increased motion, and so there's the fourth metatarsal as part of that lateral column. It has a little bit more extra motion. And so when that moves, it will grind against the third metatarsal, which is in the center and has less motion. So it can move against the nerve that's in between there and cause irritation. So I'm going to show you what that looks like here. Also, if your ankle does not have enough upward motion, which we call dorsiflexion, it allows more pressure at the ball of the foot and allowing more downward pressure as you walk, sort of like walking more on the tips of your toes. And that can cause stress in that area where that nerve is. So these biomechanical abnormalities produce conditions for increased traction and stress to the structures of the ball of your foot. There's a lot of stress at the ball of your foot when you're pushing off in gait. And there's all kinds of inflammatory problems can happen at the ball of your foot, but the Morton's neuroma is very common. So these biomechanical problems are intensified by narrow toe box shoes and with heel lifts. So the narrow toe box shoes squeezes all those bones together and puts pressure on the ball of the foot when you have a heel lift too. It puts pressure there where that nerve is. Also, if there's hypermobility of your foot, so your foot's moving around a lot and you have a bunion, this allows for shifting of all the bones, and there's more stress again to the ball of the foot because that big toe joint is not doing what it's supposed to do and taking up that load. So everything shifts over, and the bunion crowds the toes, and that may account for a neuroma to develop as well. A neuroma or a neuritis can occur between any of the metatarsal heads at the ball of the foot, but due to all the stress and the pressure through that area. However, the third intermetatarsal space or the web space is the most common due to the mobility of the lateral column that we talked about and the anatomically thicker nerve here from the two nerve branches coming together. Also, diabetics are more prone for localized areas of neuritis, in addition to the diffuse neuropathy pain that they suffer from as well. Accurate diagnosis can be made from an experienced clinician. So it has up to a 98% accuracy compared to ultrasound exam, according to one study. So you don't need an expensive ultrasound. They're not necessary to diagnose a Morton's neuroma. So diagnosis is made mainly by history and exam. There's normally exquisite pain with palpation or pressing of the bottom of the foot near the third and fourth toes. And sometimes there's a clicking with range of motion, and we call that a Mulder's click. Your doctor will need to rule out other causes such as joint inflammation, which is common at the ball of the foot, and also arthritis can cause pain at the ball of the foot. You can get even referred pain from back pathology like spinal stenosis can refer pain to the feet. Pinched nerve at the ankle or tarsal tunnel syndrome, like a carpal tunnel syndrome, you can get a shooting pain out to the ball of the foot. You got to rule out a stress fracture, plantar plate, or pressure from hammer toe deformities can cause all kinds of trouble with the ball of the foot. So one of the keys of successful treatment is treating it early before it turns from a small inflamed nerve or a neuritis into that thickened neuroma that's caused by the scar tissue and all the swollen area, making it more difficult to treat. So treatment is broken down into a non-invasive conservative treatment and invasive treatment. So conservative treatment, number one thing is getting proper shoes. So you got wide toe box shoes to decrease the squeezing of the metatarsal heads and let everything spread out. I would recommend like a rigid upturn of the outsole or a rocker sole near the toes, so that takes up that motion of push off, so your toes aren't bending and relieves that stress through the forefoot. So the shoe is helping you push off and gait. And then a softer insole that has more cushion for the nerve. And also stop wearing narrow toe box shoes or dress shoes. Stop wearing heels. That really, really aggravates the neuritis or the neuroma. Okay, so another conservative treatment is use of orthotics. So the orthotics should have a deep heel cup. They may require posting to help control that motion in the lateral column. They should be rigid, and it'll help stabilize that movement at that lateral column so you don't get that irritation on the nerve. Also, metatarsal padding will spread away the metatarsal heads and lift them off that nerve, and you can see that on my orthotic.
The tarsal pads with 1/4 inch adhesive felt. I'm going to put it on the end of my orthotic here, and it's right at the end of the orthotic, and that ends right before the ball of the foot. Just showing the ball of the foot with the metatarsal heads marked off. This is the area you want to offload so you can feel it by pushing on the bone.
Okay, the next treatment is cortisone injection. So these are used to decrease the inflammation around the nerve, so they're more helpful early on. So in my experience, they've been helpful, and like I said, early on before the nerve gets bigger from scar tissue and inflammations. One study I showed that 82% of patients with 2 to 3 cortisone injections were completely satisfied at 12 months. And that's sort of been my experience too, that if you treat it earlier, they're more likely to help you. So using ultrasound guided injections makes little or no difference to pain relief according to one randomized control study. So you don't really need ultrasound guided cortisone injections. So expensive ultrasound is not needed to do the neuroma cortisone injections. I have never used an ultrasound to do a neuroma cortisone injection. It's a very small area, and there's not many structures in that area, so it's almost impossible not to hit the nerve with the cortisone injection. So the next treatment is called chemical neurolysis. So the chemical neurolysis involves a sclerosing agent, and normally that's diluted dehydrated alcohol, and it's mixed with a local anesthetic and injected into the neuroma to stop its ability to transmit signals at the cellular level. So typically it's a 4% concentration of alcohol that's used. However, some doctors advocate for higher concentrations to be needed for greater effectiveness. This treatment, in my opinion, is difficult for patients to tolerate because you have to get a series of injections. There's a total of 3 to 7 injections given 7 days apart, and normally it's continued until there's pain relief, but you can discontinue it if there's no pain relief after 3 injections or complete resolution. With this treatment, ultrasound is important to be sure that the alcohol agent is injected into the nerve and not the surrounding structure, so that part's important. Adverse effect from the sclerosing injections include burning pain, but if the injection is ultrasound guided, this can be prevented. Numbness can occur with this, but numbness can occur anyway with a Morton neuroma. But the nerve can regrow 6 to 8 years afterwards, but the procedure can be done again. So success rates can be up to 90% when done by an experienced clinician under ultrasound guidance. So the positives are it avoids surgery and you can repeat it if needed. Negatives is there's not enough long-term data to be assured of its effectiveness, and it's painful to have done. In my opinion is it's difficult for patients to submit to the weekly injections. It is painful to get, but I have found maybe like 50% of my patients get relief with this treatment. It's not something that I jump to. All right, the next treatment is neuroablation. There's hot and cold ablation. So cold or cryotherapy. So this is a nitrous oxide ice ball at -70°C, and it's delivered to destroy the axons or the wires inside the nerves there that transmit the signals. And it's thought that the ice ball will destroy about 1 centimeter portion of the nerve. So that's fairly sizable. So the area is numbed and a small incision is made, like a little stab incision. Cryo probe is introduced with ultrasound guidance, and they find the nerve there and deliver that ice ball. So no sutures are needed. Dressings applied, can be removed the next day, and the patient reapplies the bandage. So the destruction of the axons are immediate, and so there's only mild discomfort, and that should only be felt for about a week, and then that resolves. The patient can wear normal shoes and can resume activity as tolerated. If the overlying ligament is also released, then with this procedure, then it may take 2 to 3 weeks to heal. So there's a ligament called the deep transverse intermetatarsal ligament that goes between the metatarsal bones, and a lot of times that pinches off the nerve too. So sometimes that needs to be released. If the neuroma is large, such as it's greater than 3 centimeters, and that would be a monster neuroma, then a 1 centimeter ice ball may not be able to penetrate the entire mass, so it's limited in that degree. Most neuromas do not get that big. So with this cryotherapy, there's a low incidence of complications. It's relatively painless. Infections are rare. It needs to be avoided in patients with poor circulation. The little arteries in that area are very, very small. Ice would cause constriction of the arteries, and that would not be good. It has lasting relief. It has a faster relief than the radiofrequency ablation, which is the warm ablation that we're going to be talking about, and it's 70 to 80% effective. The cost is around $3,000 to $7,000. Most insurance companies do cover it, including Medicare, which is a positive. Okay, the next neuroablation involves heat, and that's radio frequency ablation. So this time the nerve is heated to 90°C. It breaks down the nerves transmitting the pain, and the electrode is passed through a needle with ultrasound guidance into the foot, and after the area is numbed, and the electrode is heated inside the nerve, and that destroys all the little axons. Take it easy the next day. You remove it and reapply the bandage the following day. Resume activities in 1 to 2 days. Complications include infection, numbness. Pain is reported after about 1 to 2 weeks. It usually takes longer to get pain relief than the cryotherapy or cryoablation. And if the pain is not resolved after 8 weeks, they do the procedure again. So success rate is reported around 85 to 88%, and the cost is around $2,000 to $4,000, and it's covered by most insurances. Next, we have open surgery. So the first one is an endoscopic nerve decompression. So it releases that overlying ligament I was talking about, the deep transverse intermetatarsal ligament that goes between the metatarsal bones and pulls them together and can squish the little nerve underneath there. So that's been implicated in the nerve entrapment and cause of neuromas. So this is the endoscopic nerve decompression done through a stab incision with the endoscope, and it alleviates compression on that nerve. So they go in and flip the little nerve. It's done very quickly. You can weight bear immediately. Post-op course is shortened and side effects lower than traditional surgery from a larger incision. And they report 86% excellent to good results from a small study from Barrett and Walsh. The next procedure is a neurectomy, or surgical removal of a neuroma. So this involves a larger open incision, normally on the top of the foot. It can be done on the bottom foot as well, but then you'd have to be non-weight bearing afterwards so you don't get a painful scar. So it's recommended to do a surgical removal of a neuroma for large neuromas, not conducive to ablation procedures, and of course you need to fail the conservative treatment as well. The neuroma and part of the normal nerve is cut back, and the end of the nerve is usually retracted back into a muscle belly and attached there. And that's very important so you don't get what's called a stump neuroma. So anytime you cut a nerve, it wants to find the other end of the nerve and heal back together. So it sends out these little sprouts, and sometimes the little sprouts will get caught up in scar tissue and get in stump neuroma, which is awful. And the pain can be worse than the original neuroma. It's reported that neurectomies have about 20% recurrence rate, which is high. There was a study that reported 82% excellent to good results from neurectomies for Morton Neuroma. Recovery can take up to a month. The bandage is applied, and you got to keep it dry until the skin incision heals. So that takes about 2 weeks. So you have reduced limited activity. Sometimes need crutches to keep your weight off of it. But if you're on it too much, it'll swell. You'll get a wound dehiscence where the wound opens up and doesn't want to heal. You have too much swelling and bleeding. So open surgery takes longer to recover from. So surgical complications can occur, such as delayed wound healing, infection, blood clot, hematoma, or a collection of blood. Toe deformities can develop too, elevated or floating toes, because there's a lot of small little tendons in that area too that can be damaged with the surgery. And after an open neurectomy, 10 to 20% of patients report persistent pain after the surgery. And numbness and tingling can result as well. So in conclusion, you got to catch neuritis or neuroma symptoms early and modify your shoes and offload to prevent progression to a more large or more difficult to treat neuroma. It's kind of the same thing as other foot conditions. Try cortisone injections early to calm down that area. Continue offloading with shoes or Orthotics to prevent re-irritation. That's key. If persistent, look into ablation procedures, cryoablation, radiofrequency ablation by an experienced doctor, as they have good success rates and covered by most insurances. And you have limited to no downtime, so that's a big plus. Cryoablation appears to have a slight advantage over the radiofrequency option. If the neuroma is bigger than 1 centimeter on ultrasound, then surgery may be required. The endoscopic surgery, ligament release may be helpful with limited downtime afterwards. With surgical excision on the neuroma, however, the risk of stump neuroma, which is worse than the original neuroma, you have to consider that very carefully, and it's a big risk. Okay, so I've had a neuroma for about 30 years and I have never had any of those expensive procedures with the neuroablations, never had the chemical neurolysis. But luckily I was in podiatry school and I knew what it was. I was having sharp stabbing pains at the ball of my foot that would shoot out into my third and fourth toes. And I had to wear the dress shoes with the pointy toes for my clinicals. Kind of ironic. I'm in podiatry school, but I'm wearing horrible shoes. But anyway, so I knew what it was, and I soon got a cortisone injection, which calmed it down. And over the past 30 years, I've only needed 2 cortisone injections. So I primarily wear wide toe box shoes, and if I'm wearing sneakers, I'll wear that rigid sole with a little upturn, and I avoid flexible shoes. That seems to set it off. Also dress shoes, I don't wear that very often. When I wear dress shoes for an event, like going to church or even my daughter's wedding, I'll wear them extremely briefly and then take off the shoes. And usually if I'm doing any amount of walking, I will wear my orthotics. These are dress orthotics. They're real thin. They go in those shoes. And there's a built-in metatarsal pad in there, as well as I stuck on one on the bottom. And this has kept my foot from hurting for the past 30 years. It's very important. It's comfortable. I do well. I can do anything I want to do, and my foot doesn't hurt. And I hope this helps you. And if it does, please like and subscribe. Leave me some comments. I'd appreciate that. and I will see you again next time. Thanks for watching.
Please see the full disclaimer in the description. This is not a doctor-patient relationship. This does not constitute medical advice, but is for informational purposes only.